Hello, hello, hello. Okay, so this is going to be my brainstem lecture prep video. I'm going to be giving this in a long way and in a short way. I'm not going to shortchange anyone's education. So we're going to go ahead and do the long version of how to identify a brainstem lesion in terms of here, like when the limit approaches to zero, the long way of taking a derivative. And then we're going to show you the short way in terms of the rule of four. So first things first, let's kind of orientate ourselves. We're going to have the midbrain, pons, and medulla. A great way that I use to localize the midbrain is the cerebral aqueduct, which is located right here. That's why I have it in red. Also, cranial nerve number 3 kind of looks like these little spider webs coming down. When I do the pons, I see the fourth ventricle, but honestly, what helps me differentiate between the pons or the medulla is this thing called the inferior olivary nucleus, which is part of the cerebellum. That's why it's in red, because it helps me differentiate between the medulla and pons since they both have fourth ventricles. So right now we're going to go ahead and take a deep dive into the midbrain here. I went ahead and highlighted key important structures that are important clinically to the localization of different strokes and infarcts of the brainstem. As you can see here, we have the spinal thalamal tract, which is responsible for pain and temperature. I put all the important stuff on here as a guide. And again, we'll go ahead and talk about contralateral, ipsilateral when we get closer. But overall, this is just kind of basic terminology. Medium lemniscus. We have the proprioception and vibration. Red nucleus is part of the midbrain as well, which is fine-tuning of movements. And then here we have the we have the cerebral peduncle, which basically carries motor fibers. And within that, we have the cortical spinal and cortical bulbar tracts, which, if there's a lesion, causes upper motor neuron and paralysis. And then this will, again, just for completion's sake, will be contralateral because it will go down and desiccate through the pyramids. And then we have the medial longitudinal fasciculus, which you can see the abbreviation right over here, which basically is responsible for lateral gaze. And if there's a defect, you get intranuclear ophthalmoplegia. So the first lesion is going to be localized right around here, and it's going to be called Benedict syndrome. You're going to get a problem with cranial nerve number 3, then also the medial lemniscus and the red nucleus. Okay, when you have cranial nerve number 3 problem for the ocular motor nerve palsies, you're going to get an eye that is down and out, and you'll have your pupils will be dilated on that specific side. Then, because we have medial lemniscus problems, you're going to have contralateral proprioception vibration, essentially damage to the medial lemniscus pathway. Then, again, as the red nucleus is right there, as you can see it's labeled there, you're going to get damage there and you'll have involuntary movements with tremor and ataxia. Again, Benedict syndrome, part of the midbrain. Then Weber syndrome, again, you can see it's a little bit down here, so you can look on the other side and see what's affected. Well, I tell you here, cranial nerve number 3 and also the cortical spinal tract, CST. Then you have the cortical bulbar tracts. Again, cranial number 3, ocular motor nerve palsy, down and out, dilated pupil. You're going to get contralateral hemiparesis because you get loss of the cortical spinal tract. Again, contralateral because we're above the desiccation of the medulla. So obviously it's going to be the opposite side. And we know the cortical spinal tract is responsible for the whole motor, right? Then you're going to go ahead and get a pseudo bulbar palsy with an upper motor neuron cranial nerve motor weakness. You're going to get exaggerated gag reflex, tonspastic. Again, no wasting. And you're going to have spastic dysarthria, which you can go ahead and Google on or YouTube it to see how that looks like. So then you have the Pernard syndrome. This is going to be an infarct way above, essentially right above the cerebral aqueduct. It's the posterior midbrain near the superior colliculus in the pretectal area. So you're going to have a vertical gaze palsy. You can't look up. So there's something called a pseudo Argyll-Robinson pupil. Essentially, this does not. So whenever you shine a light in someone's eyes, they're not going to constrict. The only time they constrict is only through accommodation. Now you can also see this through neurosyphilis, but definitely you're going to see them through if you have an infarct in this specific region. And you can also see this with the pinealoma or germinoma of the pineal region, which again is compression of the posterior midbrain. Now you got to watch out because here's your cerebral aqueduct, which is one of the things that I use to localize the midbrain. So you can get something called a non-communicating hydrocephalus, and again you get that compression of the pineal tumor. Now, we're going to go ahead, shift down, go into the pons, and we're going to go ahead and take a look at it. So a couple more new, cranial nerves. You're going to get vestibular nerve here, cranial nerve number 8. So if there's a problem there, you're going to get nausea, vomiting, vertigo, nystagmus. Here's something cool. As you can see, cranial nerve number 6 here comes in and wraps around this specific, if you go down here, this nuclei, it wraps around cranial nerve number 6, which is really interesting. We'll talk about it here. And then if you get problems in cranial nerve number 7, you're going to get facial droop and also loss of the corneal reflex and also some other things which we'll discuss. Again, you have your medial lemniscus, proprioception, and vibration. We're going to keep repeating this. Repetition is the mother of learning. Then we have cortical spinal tract, which is hemiparesis. Then we have cranial nerve number 6, which then attaches it to the lateral rectus. It's if you have problems with this, you have problems with lateral gaze. Again, the spinal thalamic tract, pain and temperature. Again, these are all go through the medulla, so it's going to be contralateral. We'll get there. We also have something called the spinal tract and nucleus of the trigeminal. This is going to be pain and temperature of the face and sensation to the face ipsilateral because it is part of the trigeminal. Then again, you have the abbreviations down here. You have this location right here called the paramedian pontine reticular formation, which is also responsible for lateral gaze. And you have the medial longitudinal fasciculus, which if there's damage there, you get intranuclear abdominoplegia. Mind that the location is important. So normally the PPRF here, the paramedian pontine reticular formation, ends up synapsing on cranial nerve number 6, which then helps move the let's say if you want to gaze right, move the right eye to the right there. But also you're going to get the PPRF synapsing on nuclei of the 6th cranial nerve, which then goes through the medial longitudinal fasciculus, which then synapses on the 3rd cranial nerve, which then is able to let the eye gaze to the direct, like, for example, if you want to move the eye to the right, then the other eye is going to end up moving medially because the oculomolar nerve is going to synapse. I'll go ahead and explain that a little bit further with a diagram. But you can see how they're all connected here. And this is obviously structure is equal to function, which you hear a lot in undergrad. So now you have the medial pontine syndrome, okay? So now we're going to get, in the medial version here, you're going to get damage to the cortical spinal tract, cranial nerve number 6 and 7. So because of this cortical spinal tract problem, you're going to get contralateral hemiparesis. You're going to get a cranial 6 palsy. And because you have cranial nerve number 7, you're going to get facial weakness, droop affected side. Then you got that lateral gaze structures. So you have your MLF, cranial nerve number 6, nucleus, and the PPRF. So you're not going to be able to do lateral gaze. You can't, here's the beautiful part here, because it's a PPRF problem, you can't look to that affected side, right? So that's going to be a good telltale sign you have damage to a PPRF. And the basilar artery is going to be supplying this region, and we're going to have a nice little, not mnemonic, but a really structured way to remember this. Here you have the lateral pontine syndrome. As you can see, the infarct is in this particular area, so you can kind of track to see where it's going on. But just to make it easy for you, you're going to get vestibular nuclei, nystagmus, vertigo, nausea, and vomiting. You're going to get spinal thalamic tract, contralateral pain and temperature, again, because it does have to desiccate to the medullary pyramids. Then you're going to get ipsilateral spinal trigeminal nucleus, so you're going to have loss and sensation, pain and temperature of the face. You're going to get synaptic tract Horner syndrome. It'll be ipsilateral. But I starred this and I put it in red on purpose because lateral pontine syndromes, this is how you're going to be able to localize the lesion. Okay, you're going to get a facial nucleus. You're going to get ipsilateral facial droop, loss of the corneal reflex. Again, cranial nerve number 7, right? And you're going to get decrease in lacrimation, salivation, and taste from the anterior 2/3 of the tongue. And again, I wouldn't say clinically this may not be as relevant as the one that I'm going to show you now, but it is a differentiating factor. So maybe on exam, you'll be able to pick that up on like a board question. Then you have the cochlear nuclei, deafness, and you have the ICA here, the anterior inferior cerebellar artery stroke. Now we're going to go to the medulla. So a couple of new things in the medulla. We can go ahead and review all these here, but we already talked about all these tracks. One things that are new is the nucleus solitarius and the dorsal motor nucleus of X here. So you have autonomic sensory info comes in. So you're going to get sensory information coming from, let's say, the carotid body, the aortic arch, a lot of sensory modalities coming in. So this will be definitely important for that region here. What's also interesting for the nucleus ambiguous, you're going to get shared motor nucleus of 9, 10, and 11, right? But then it goes ahead, connects, and sends out fibers through cranial nerve number 10. So you could kind of almost think of your gag reflex there too. So kind of setting the pavement of the way for a lateral medullary. So we'll go there. So first we're going to talk about medial medullary syndrome, which is located right there. You're going to get a cortical spinal problem, medial lemniscus, and also cranial nerve number 12. Again, this story repeats itself. Cortical spinal tract, you can get a contralateral hemiparesis. Medial lemniscus, you're going to get contralateral loss of proprioception vibration. And because of cranial nerve number 12, you're going to get a flaccid paralysis of the tongue. Again, lower motor neuron region, flaccid paralysis. But here's the thing, deviation is going to be towards the side of the lesion. So you can always say the tongue licks the lesion, something like that, right? Then you have this is part of the anterior spinal artery. And again, if you go down a little lower in the spinal cord, you can also get infarcts in that region, and it'll be the anterior 2/3 of the anterior part of the spinal tract, right? The spinal cord, right? So you can imagine the type of defects you'll get there. Now, from honestly, one of my favorites, it's a lateral medullary syndrome, Wallenberg, nice little name there. But you can see the defect is right there, and you can, obviously going to get the, vestibular nuclei, nystagmus, vertigo, nausea, vomiting. You're going to Horton syndrome. You're going to get a contralateral pain and temperature loss because of your spinal thalamic tract. You're going to get the ipsilateral face loss, for the loss of pain and temperature and sensation to the face because of the spinal trigeminal nucleus. But the biggest one is the nucleus ambiguous. Remember how I mentioned it here? It's literally right on top of the nucleus ambiguous. What you're going to see patients, and I've actually had a patient last week, he had a problem with hoarseness and dysphagia and a decrease in his gag reflex. And, this is a telltale sign that you're looking at a lateral medullary syndrome. This is clinically important, test important, really important. And the infarct area is going to be the posterior inferior cerebellar artery, right? So that was a lot to remember. Most likely, you're going to probably forget that. If you don't have some, repeat it multiple times. So there is, I believe a physician created this, excuse me, by the name of Peter Gates. This is a non-neurologist way to remember kind of the anatomy and the vascular supplies of the brainstem. So I think this is extremely helpful and definitely something that we should consider. So rule of fours. So I'm going to go ahead and walk you through this mnemonic or this way of remembering structure, and you will never forget any brainstem lesion, and you will be better than 90% of, I would say, people that look at brainstem infarcts. You're going to be gold. So here's the rule of four. You got to think 4 cranial nerves for the medulla, 4 cranial nerves for the pons, and 4 cranial nerves above the pons. Just follow the logic right now, and we'll go ahead and, just like ice, we'll go ahead and sculpt it as we go on. So 4 cranial nerves divide into 12, right? So if you take 3 divided by 12, that is divisible. Is 4 divisible by 12? Yes, it is. Is 6 divisible by 12? Yes, it is. Is 12 divisible by 12? Absolutely. So all numbers, all cranial nerves that are divisible by 12 are going to be midline for motor nuclei, right? Motor nuclei are midline. So any cranial nerve that is divisible by 12 is going to be in the midline of the brainstem. Now, 4 cranial nerves that do not divide by 12, like for example 5, 7, 9, and 11, those are lateral. So cranial nerves 5, 7, 9, and 11 are lateral. Now for your tracks, 4 midline columns, you get the motor nucleus, motor pathway, cortical spinal tract, right? The medial longitudinal fasciculus and the medial lemniscus. These are all starting with M. M for midline, right? So these are going to be, if you have infarcts, if patients have, for example, issues with the motor nucleus, motor pathways, and all of these different types of things, you can localize the lesion towards the middle. And there's one thing I just remembered I'm going to add. I'm going to add some cases to this lecture here so then people can apply their knowledge. Okay, so then how about lateral sides of the brainstem, right? So that's the sides of the columns, right? So you have your sympathetic, you have your spinal thalamic, your sensory, your spinal cerebellar. Get it? Starts with an S. It's on the side. It's lateral. So when we want to localize a lesion, think of the Cartesian plane. You have the y-axis and x-axis, okay? So as you transcend above the y-axis here, that is your ability to essentially go from the midbrain, pons, and medulla by the number of cranial nerves. And again, we'll dive specifically in there. For example, cranial nerve 1 and 2, you're not going to be able to find in the brainstem. Then on the Cartesian plane of the x-axis, you're going to go ahead and look at whether it's medial or lateral. You're going to localize it whether it's medial or lateral, okay? And we'll go ahead, and those are your midline structures, your M's or your S's on the sides, lateral, okay? So 4 above the pons. So olfactory and optic, those are out. Those are not in the midbrain, okay? The ocular motor nerve, cranial nerve number 3, eye turned out and down. Cranial nerve number 4, trochlear, eye unable to look down when looking towards the nose, or, you'll have patients sometimes have a hard time going down the stairs, okay? So 4 pons, and 4 cranial nerves in the pon region, so trigeminal, ipsilateral facial sensory loss, abducens, ipsilateral eye abduction weakness. So again, essentially moving the eye out, right? Lateral gaze, okay? Cranial nerve number 7, facial, ipsilateral facial weakness droop. Again, ipsilateral, right? Cranial nerves here, okay? Auditory, cranial nerve 8, ipsilateral deafness. Now, for the medulla cranial nerves, you got the glossopharyngeal nerve, cranial nerve number 9, ipsilateral pharyngeal sensory loss, vagus nerve, ipsilateral palatal weakness, spinal accessory, ipsilateral shoulder weakness, then the hypoglossal ipsilateral weakness of the tongue. So now we went over the cranial nerves. Now we're going to go over our M's. The motor pathway, cortical spinal tract. Again, these are going to be your midline structures. It'll be contralateral weakness. Again, this is the cortical spinal tract. There's a cortical spinal tract also in the spinal cord. But how does it get from the brainstem all the way to the spinal cord? It has to desiccate the medulla. And we're in the this is a little higher up before it desiccates, so it's going to be contralateral if it's in the brainstem, okay? Medial lemniscus, same story, loss of contralateral proprioception and vibration. Medial longitudinal fasciculus, ipsilateral intranuclear ophthalmoplegia. Again, these are all, this doesn't have to do with the medullary pyramids, okay? Motor nucleus and the nerve, again, ipsilateral for the midline structures is anything divisible by 12. Remember that? 3 and 4 and 6 is all divisible. Also, 12 is divisible by 12. And those are all going to be in your midline structure. So you see how you're starting to get kind of a little mnemonic of structure of how to localize these brainstem lesions. Now, for your side lateral structures, you're going to essentially go ahead and look at the spinal cerebellar pathway. That is going to be ipsilateral ataxia, spinal thalamic, contralateral pain and temperature sensory loss, sensory nucleus of the cranial of the trigeminal. You're going to ipsilateral pain and temperature loss in the face, and then sympathetic pathway, ipsilateral Horner syndrome. Again, lateral structures on the side. So here are the caveats. When you go ahead and try to look at the trigeminal nerve, I don't want you to localize it to the pons. It extends a little bit, a little down. So you want to do is, instead of looking at the y-axis as trying to figure out whether it's in the midbrains, pons, or medulla, just follow on the x-axis. Is it divisible by 12? No, it's not. It's lateralized. It's a lateral track. Boom. Done. How about number 8? Again, it's one of those, oopsies. It's one of those other big ones as well. So you want to go ahead and don't use the y-axis. Just x-axis, try to lateralize it, hearing loss. Okay, here are the blood supplies. In the midbrain, you're going to get a PCA infarct, both laterally and medially. So it's a great way to remember brainstem infarcts. In fact, on an exam, you could just draw these out. It's just an easy way to remember. And I'm going to beat a horse dead, or whatever the saying is, which is very disgusting saying, honestly. But you have the 3, 4, and 6, and 12. So 3 is divided by 12, 4 divided by 12, 6 divided by 12, and 12 divided by 12. These are all divisible by 12, so there's going to be midline regions. 3, 4, midbrain. 6, pons. 12, medulla. Again, 5 and 8. Don't try to localize it to the pons. It gets a little messy. But understand that 5 and 8 is not divisible by 12, so it's lateralized, so is 7, so we can lateralize that. Same thing with 9, 10, and 11. Those are lateral infarcts. And again, you get a lateral pontine ica, lateral medullary pica. Again, medial pontine basilar, medial medulla, there, look at that, medullary, anterior spinal artery. See how beautiful that is, guys? Again, we're going to go ahead and continue, repeating this. A cranial nerve is divisible by 12 in the middle, not lateral. Motor, M, motor nucleus, motor pathway, medial longitudinal fasciculus, medial lemniscus. These are all midline. Same thing here, sympathetic, spinal thalamic, sensory trigeminal, spinal cerebellar, lateral. Okay, just very quick, we talked about this, but the PPRF, because we talked about PPRF, and I just would feel I'm shortchanging people's education by not mentioning this. So the paramedian pontine reticular formation, which synapses on to the cranial nerve 6 of the abducens, which then goes ahead and touches the lateral rectus. For the goal is to move the eyes to the right. The problem is you got to tell the other side what to do. So the PPRF goes ahead and signals the cranial nerve 6 with the abducens, which is connected contralaterally to cranial nerve number 3, which is the ocular motor nerve, through the medial longitudinal fasciculus, which then goes ahead and tells the medial erectus to go ahead and look on the same other eye, right? To go ahead and look right. And again, this is the same thing. Remember the pons, again, the PPRF, the MLF, all of these components here, cranial nerve number 6, and then also the ocular motor nerve, these, you can see they're all connected, again, structure function. Now, just very quick, what is internuclear ophthalmoplegia? Again, if you have a left internuclear first off, normal, this is how it looks like at rest. If you want to do a right gaze, works. Left gaze, everything works. If you have a left internuclear ophthalmoplegia, if you want to go ahead and do a left gaze, yes, it works. But if you want to do a right gaze, this left eye cannot go into the direction towards the right. It cannot gaze, and it has to deal with this pathway I talked about. Same thing here. The right internuclear ophthalmoplegia, right gaze is okay, but again, that right eye can't do that left gaze. And again, this is some other stuff here, just in case someone asks me about, MLF, affected side can't move. Like, for example, PPR. I always forget these two here. Now I said that I'm going to forget. I'm probably not going to forget. But PPRF lesion now can't gaze to the side of the lesion. And then the frontal eye fields here, lesions, eyes deviated towards the side of the lesion. So this kind of, it's like almost like tongue, like hypoglossal nerve. The tongue points to the side of the lesion. Same thing here. This is the PPRF is opposite. And that's pretty much all I have when it comes to the brainstem. And yeah, that's my presentation.